Hello and welcome to the next episode of the Complete Physio Podcast. My name's Chris and I'm joined today by an extremely experienced sports medicine doctor that I've known for many years, too many to mention. And today we're going to be talking about injection therapies. Now, when me and Lorenzo started injecting 20 years ago, we generally would see lots of joint and soft tissue problems and we would inject steroid. Now, we're going to be talking about all the different types of injections, particularly that Lorenzo uses in his practice, and how that fits into an overall treatment program. So we see lots of tendonitis, tendinopathies, joint osteoarthritis, lots of different conditions. So Lorenzo, do you want to just give us a flavour of how injection therapy fits into your overall practice at the moment?
Thanks, Chris, for inviting me. Generally, I use injections. I see a lot of general musculoskeletal conditions. So I see osteoarthritis, I see tendonitis, a lot of overuse conditions in patients, both active and inactive. So for me, the injections are always an adjunct to other therapy, and generally it's exercise therapy that is the default for most non-traumatic musculoskeletal conditions. Mm-hmm. So I tend to use an array of products. Overall, I think I'm been practicing now for about over 20 years, I think. Overall, certainly my use of cortisone has significantly diminished. So the therapeutic for cortisone is rapidly shrinking. And if I haven't looked at the data formally, but certainly if I were to look at that data formally, I would see a trend towards reducing cortisone for various reasons that we hopefully will talk about today, and increasing other injectables, particularly hyaluronic acid and PRP, as the injection adjuncts to therapy.
So definitely on this episode we're gonna go through all these different types of injections that we can do. We've mentioned steroid, we've mentioned platelet-rich plasma, so PRP injections, which we all know, lots of footballers will get injected and that sort of thing. Hyaluronic acid, which we've both been using for quite a long period of time. And then lots of people are asking me things around stem cells. There's lots of other products, such as something like arthrisamid, which is used for arthritis. So we'll go through all of that, but let's start with steroid. What are the positives of steroid, and what are the negatives that I think have got more press recently as to why we're probably using it less at the moment?
Sure. I think we know steroid is predictable, right? So as a general rule, if patients have a cortisone injection, they are going to get some relief from their pain, particularly if osteoarthritic pain, and even in tendonitis. The problem with cortisone is, firstly, it doesn't last that long. So we know the effect is only going to be short term, and I often tell people it's not a fantastic drug. It will give you a short term reduction in pain. But we know that after 6 to 8 weeks, that effect drops dramatically. In fact, the way I broach it to patients is I often say I use cortisone as the holiday drug. So, you're going on a holiday, you're going on a hike, you want to
Your daughter's getting married.
You want to build a house, you've got an exam coming up. Cortisone's fantastic. It's the holiday drug. So I tend to use it, this time of the year, and it's winter. People want to go skiing. They've got a bit of knee osteoarthritis, or they've got some sort of tendonitis and they want some relief. They want to go hiking in the summer, same sort of principle. I tend to use it for those cases. But as a method to help people in the medium to long term, it's not a great drug, particularly. So that's the first thing. So as a drug itself, not fantastic. However, and certainly in the last 5 or 10 years, what we've seen in the studies is that there is increasing concern about harm. And this is the issue that I have with using a lot of cortisone for musculoskeletal conditions that I tend to see, which is tendonitis and osteoarthritis. So, for example, with knee osteoarthritis, there are increasing studies that show that if you have more cortisone injections, in the medium to long term, you'll get increased pain and potentially an acceleration towards knee replacement. With tendonitis, we see a similar sort of principle. For example, with tennis elbow, we know that if you have a cortisone shot for tennis elbow, you'll do better at 6 weeks, but you'll actually do worse at 3 months and 6 months than if having no treatment at all.
Yeah.
So we have these concerns about potential for harm in studies, but also anecdotally. I mean, we see it. I'm sure you see it as well with patients that have had cortisone injections and have had potential ruptures, flares of their joints, skin issues.
Yeah.
These are all the issues that you need to think about before you consider injecting cortisone in patients.
Yeah, and I think both me and you do steroid injections for certain conditions, and we can talk about what we feel are the best conditions for steroid, because there's certainly a role for things like frozen shoulder. And I think our thought process, as you rightly said there, is you're going to get that short-term relief, and if you can use that short-term relief positively, i.e. get your knee stronger, get exercising more, or just get a good night's sleep, then things can start healing and maybe get a little bit better. The issue is that long-term effect, is that if people think that this is going to be the long-term solution to their problem, because it's generally not going to be, is it? And I think that's where the other injectables have come in a little bit more, is because they've not shown any of the detrimental effects that steroids can sometimes have, which is worsening of pain in the medium to long term. So I think it's changing a lot. So yeah, go on.
So for me, I tend to use cortisone, as a stopgap measure to help people for the holiday drug, as I mentioned. But where I see problems with cortisone is that people rely on it for their pain relief.
Yeah.
And one of the downsides of cortisone that I've seen, particularly in my practice, is that sometimes it works too well in the short term. So that's a funny statement. You want pain relief, but the problem that we have is that, say you've got a painful shoulder and I inject your shoulder, right? I get rid of your pain completely for 6 weeks.
That feels pretty good.
It feels great, but then how do you know where you're at with your shoulder in that time? And what I tend to see with some patients, and this is something that I discuss with them, is that if I get rid of your shoulder pain, are you going to trust yourself to do the rehab in that 6 to 12 weeks? Or are you just going to jump back into the gym or your particular sport because you're now pain-free? And
it's almost like, well, why do I need to do the rehab? I feel great.
Exactly. I feel great. I don't have shoulder pain anymore.
Yeah.
And, when the cortisone wears off at 6 to 8 weeks, you may be in a worse situation than you are before you had the cortisone injection. So I think some of the issues that you have to discuss with the patient are, yes, it will get rid of your pain, but you need to engage in progressive rehab, and it needs to be slow and graduated.
So it's patient education, like all of this I'm sure we'll talk about today, is informing the patient of the pros and cons. Where does a steroid injection fit into your overall treatment program?
Exactly.
And managing their expectations, particularly in the medium and the long term.
Absolutely. So some of the conditions that I think cortisone works really well in, and you mentioned it, I think frozen shoulder, fantastic drug for frozen shoulder.
I think if me and you had started to develop frozen shoulder today, we would have a very low threshold for a steroid injection.
I would have an injection immediately. And I think, there's also evidence that if you get frozen shoulder early, before it starts to really freeze, you get a better outcome.
And so more, in 3 weeks after my first injection, if I was still in significant pain, but better, I would have another one.
Yeah, I think for frozen shoulder, very liberal in the use of cortisone injections. Certainly for inflammatory arthritis, if you've got someone who's got a roaring gout or rheumatoid arthritis or seronegative arthropathy, I have no issues with injecting cortisone into those joints. Then when you're looking at degenerative changes, osteoarthritis, again, tend to use it sparingly, but there is a role for it. And I certainly think that, if you've got someone who has got severe pain, they're not settling with anti-inflammatory treatments or conservative management, I think cortisone injection. Some tendons, I still inject some cortisone. So rotator cuff tendonitis, whatever you want to call it, subacromial impingement, subacromial pain. There is a role for that. Calcification, I think definite role.
Definitely.
You've got calcific tendonitis. I think, barbotage procedure plus or minus cortisone injection. I think a very good injection. And then for other tendinopathy, probably not so much. So certainly I wouldn't inject cortisone around a weight-bearing tendon.
Yeah,
and
so Achilles.
I haven't done a cortisone injection for Achilles tendinopathy for over I don't know, 15 years.
Yeah.
Just don't inject.
No.
I don't care if it's retrocalcaneal bursitis or if it's a mild paratendonitis. I just think the benefit risk ratio is so far tilted towards the risk that it's just not worth their while.
What about plantar fascia?
I mean, certainly I'm doing them a lot less than I was 10 years ago. And I just, again, think the risk of, potential harm, even if done under ultrasound guidance, and I think if you're going to do a plantar fascia injection, you should do it under ultrasound guidance. Even if done under ultrasound guidance, there's a risk of, complications. You've got rupture, which can lead to its own problems. You've got fat necrosis, you've got skin changes. So there's lots of structures around there that you need to be really careful of.
Yeah.
I certainly tend to reduce and default to non-invasive options.
Yeah.
Shockwave therapy, exercise therapy, and so forth.
Yeah.
So even in plantar fasciitis, I've reduced.
The other one I think of, and I think you'd agree, is the AC joint. It's quite a nice one for a steroid
AC
injection.
Joint, good injection, I think.
Yeah.
Does it work well? It doesn't. Some people think it's worth a go, maybe one or two, and then if that doesn't work, then you might want to move on to other injectables or potentially discuss role of surgery.
Yeah, absolutely.
In case AC
so in conclusion on the steroid, there's a role in certain conditions, but we need to make patients aware of how that fits in, and certainly, 15, 20 years ago.
Yeah, I mean, how many? Would you agree that you're doing less cortisones?
Without a doubt, I'm doing less, but I'm definitely still doing them. I see a lot of frozen shoulder, and it can be a wonder drug for frozen shoulder. And I think as we're more aware of the pros and cons, I think I am taking my time a lot more to manage the patient's expectations around the role of steroid injections. And importantly, making them aware that, this is a great drug that can help, but are you also aware that it could be detrimental to your joint in the long term? Obviously, a lot of that research has been done on repeat steroid injections, which, to be honest, that hasn't changed for me. We aren't injecting people 4 or 5 times with steroid, or even 3 or 4. So I think, because we're informing patients so early around the pros and cons, I think a lot of the time patients will actually make their own mind up, and actually that is what they're doing at the end of the day. But I've had lots of patients where, I didn't realise there was any negatives to this.
I was going to say that it's surprising, and this is something that I've noticed more and more. It's surprising when you broach the subject of harm.
Yeah.
Any injection can cause harm.
Any drug
can cause harm. When you broach the subject of potential harm, it could make it worse. People are quite surprised, taken aback by it. And they're like, "Oh, I didn't realize that. If I had an injection in my shoulder, that I could actually get worse." A lot of people dismiss the infection risk because it's so low. I mean, it's a valid risk, right?
Yeah,
you need to.
You've got to explain it.
Got to explain it. But most people say, "Oh, well, 1 in 10,000." But do you realize that there's probably a 1 in 30 chance, 1 in 20 chance you might get worse with this injection. It actually might deteriorate. That figure might change depending on the tendon injected or the joint injected. So it's interesting when you broach the subject of harm, people step back and reflect a little bit and then think about it. And I think that's a really important way of coming to a shared decision about injections.
Absolutely. And I think providing the information as early on in the process as possible in terms of patient information leaflets and that sort. And partly why we're doing these podcasts is to try and get people more informed to make more of an informed decision around their own care, which at the end of the day, we don't sit there telling people they need to have a steroid injection. Somebody will need to find out the pros and cons, and then they come to you saying, look, I appreciate this, but I can't sleep at night. I haven't been able to walk my dog for two years. When I weigh it up, I feel like my quality of life may have a chance of improving.
There was a very touching experience I had a few years ago where I saw this elderly gentleman who had shoulder osteoarthritis, and he came to me in early summer wanting an injection because he was in quite a lot of pain and he wanted to enjoy his summer. I thought, that's reasonable. He's got shoulder osteoarthritis. He's, just retired in his late 60s. I had the cortisone injection. I followed him up on email, but 6 weeks later he didn't reply to me, and that can happen. And then about 3 months after that, his wife contacted me by email and said, unfortunately, my husband passed away,
Right.
and that's why he hasn't replied to your email. But she thanked me for giving her the opportunity to experience summer with him, pain-free.
Yeah.
He was able to swim the whole summer.
Yeah.
And she thought that was,
Yeah.
they were memories that she would always keep
And
forever.
I think that's
so. I think we've got to look at the risks and benefits,
but also you have to, and this is where I think other clinicians can be quite judgmental. Is it has to be on a case by case basis.
Exactly.
Because what means that holiday to him and his wife meant everything.
That's right.
But if you say to a clinician, well, he or another clinician that doesn't inject steroids, say, well, I wouldn't have done that, I would have done X.
Sure.
It wouldn't necessarily have had the same outcome. So,
exactly. So I think you also got to look at quality of life.
Yeah.
And I think we're moving maybe toward it to the other extreme where we're saying, don't use cortisone for anything because it's harmful. Whereas I think we need to keep on that middle road where we're looking at pros and cons, patient decides, and looking at quality of life issues as well.
Yeah.
So I think judicious use is probably better.
Absolutely.
Judicious use of cortisone.
And in 20 years, I'll still be alive, I'm sure, hopefully. Steroid will still be used. Steroid, it's been around a long time. It's not going anywhere. However, the use of it, certainly in our circles, has reduced. There's
Absolutely.
no doubt about it.
And it might reduce further. We might have other products that we use that are better than cortisone, but I still think it'll play a role, some role, in certainly our overuse.
Absolutely. And I think although we've decided to talk quite generally today, how you manage a tendon, a weight-bearing tendon such as an Achilles, is going to be very different potentially to how you manage, say, an upper limb tendon. So there's been this sort of, we're more aware now of the pros and cons of steroid. Is that the reason why you're now finding a lot more different new injectables, or is it because these new injectables are that good? So if we think about the steroid is the one that we've been using a lot.
I think it's a bit of both, really. I think we're understanding that there's potential harm for cortisone, certainly repeated cortisone injections, and we're now looking at other potential options where there may not be that harm, and in fact we might get the same or similar effect, potentially longer effect, with other drugs. And certainly in my practice, I've been using a lot more hyaluronic acid and PRP as a substitute for cortisone injections.
So do you want to just go through what those two are? And because those are the two main other injectables that we use in practice.
So hyaluronic acid is actually a naturally occurring substance that we found in joints. It's found in synovium, and we often use it as injectables primarily for joints, so for osteoarthritis, primarily degenerative change. Occasionally we'd use it for tendons, but certainly in my practice I tend to limit it mostly to osteoarthritis.
And it's not a drug, is it? It's not a drug. It's a medical device, so less side effects.
Basically, we're reconstituting what we have in our body. It's slightly modified. So depending on what type, there's different types of hyaluronic acid. We can go through a little bit of that if you want, but in essence, it's the same product. It's just reconstituted. As you would reconstitute any drug. And it's hyaluronic acid that you inject, usually by ultrasound guidance, because you want to be accurate, into a joint. And what it does, we don't exactly know the mechanism of action, but we think it has multiple effects on reducing inflammation, so balancing that anti-inflammatory response that we see in osteoarthritis. It also has a lubricant effect. We think it binds to certain receptors in the joint that might have an anti-inflammatory effect. So there's a number of proposed hypotheses as to how it works.
Because it's certainly thicker than steroid. It's a bit more viscous, isn't it? So
and we
that idea of lubricating, oiling the joint.
The big difference between hyaluronic acid and cortisone is you don't get that kicker that you get with cortisone. Cortisone, predictable, as I mentioned, you get a great effect at a week to 2 weeks, and then that tends to last for 6 weeks. Hyaluronic acid tends to be a little bit the reverse, where you may even get a grumpy joint for a little while, so you might get it for a week or two, where it feels a bit grumpy, and then you start getting a positive effect, usually at 2 to 4 to maybe 6 weeks. And then the long-term benefit is, or the benefit compared to cortisone is that usually, if it does work for you, it usually lasts for, even up to 18 months in some cases.
But it is normally an injection that's repeated, isn't it? Because you're going to have osteoarthritis generally, or a degenerative meniscal tear.
Yeah, so most of the injections we have will degrade. Yeah. So they're all, any injection we have, and there's some exceptions to that, which we might talk about today, but generally they all degrade. So they tend to last for, 6 to 12 months on average, and then you can have a top-up injection.
But you don't have the detrimental effects like potentially with repeat steroid with
Absolutely.
hyaluronic.
In fact, what we see with hyaluronic acid is there could be a protective effect where you see this delay to going on to surgery. So delay to total knee replacement or delay to total hip replacement.
We've definitely have experience of that, don't we? With
where
patients?
we have certainly cohort studies have been done looking at patients that are on waiting lists for surgery. They have hyaluronic acid. Half of them have hyaluronic acid, the other half don't. And you find the ones that have hyaluronic acid have this delay to progression. Now, is that a protective effect or is that just a pain relieving effect? It might be a bit of both, but it certainly is not a negative effect that we see with cortisone cohort studies.
Yeah.
So cortisone, you see this progression to knee replacement, whereas with hyaluronic acid, you see this delay. So probably a combination of protective and also pain relieving.
Yeah, and it's not unusual, certainly, that surgeons will request a steroid and a hyaluronic acid together, which can be done under ultrasound guidance at the same time. What's your opinion of that sort of combo?
I'm not such a fan of combinations. The reason for I'm not such a fan is that we know that, in vitro studies, or studies in the lab, have shown that if you actually combine cortisone with hyaluronic acid, the cortisone breaks down the hyaluronic acid, so it might make it less effective.
Yeah.
So my preference, if you've got someone that needs a cortisone for that effect, is to do that first.
Yeah.
Wait the 6 to 8 weeks, and then maybe do a hyaluronic acid. But I can see, you could make a shared decision there. And patients say, actually, I'd rather just have one injection and have the
And then it comes
injection.
down to as well the clinician preference, doesn't it? So I know two surgeons I work with that every time they send to me for an injection, it's generally a steroid and hyaluronic acid. But the decision has been made that they are going to have surgery at some point. So I think it's just a question of getting through to that point, really.
To that point, yeah. So I try and avoid that, but certainly I have done it in the past, and I think it just depends on patients' previous experience. Maybe they've had a combined injection; it's worked very well for them. So you'd sort of say, okay, well, we might try one more.
Yeah.
But my preference would be to separate the two. The other issue with hyaluronic acid is not to use too much local with it, because again, local can have
the local anaesthetic when you're doing it.
When you're doing
could break it down.
Could break it down. So I try and use less local anaesthetic if I can, or dilute the anaesthetic. I mean, whether that has a true clinical effect or not is it's hard to measure.
And probably about 80% of hyaluronic acid injections, certainly that I'm doing, will be a knee joint osteoarthritis.
Yeah, exactly.
Hip and ankle, first toe joints, I've used that as well with
so
mixed results.
But I've used it for shoulder.
Yeah, same.
I've used it for thumb joint, first CMC joints. Foot and ankle, I've used it with some success, but as a general rule, hip and knee are the joints that I tend to use.
And I find if we talk about the knees, because one of the things that we can talk about is what patient is going to respond to what injection. So if we had 100 knees in the room, it is very hard to know who's going to respond to hyaluronic acid and who isn't. For me, anecdotally, my perfect profile for a knee is somebody with mild to moderate osteoarthritis, who's not overweight, and that is an important part to mention, because we know the outcomes are poor with people that are overweight. But also somebody that is reasonably active. So not somebody that's struggling to get off the chair, but somebody that's struggling to walk.
Chris, I think that pertains to any injection.
I was about to say that. Yeah.
So I think for cortisone, it's the same. For PRP, it's the same. For any other injection we're talking about, it's the same. Mild to moderate osteoarthritis, not obese, who is relatively active, who is fit, who likes exercising. I think they're certainly a better candidate. Now, we can talk about PRP and some of the specifics there, but as a general rule,
Yeah.
if you fit that profile, you'll respond better to any injection.
Yeah.
So why do a hyaluronic acid versus a cortisone? We've just talked about that. Why do it compared to other injectables? As a general rule, hyaluronic acid is
cheaper than the other, and we do have to consider that.
So it's cheaper. It's usually one shot. And, I think if you look at the evidence, probably got a 70% chance of responding overall. Again, if you're milder, probably a higher percentage. If you're more severe, lower percentage. So 70% chance, cheaper drug, might last for 6 to 18 months. I think a reasonable option.
Yeah.
And that tends to be my first option for most osteoarthritis, unless patients want something else for whatever reason.
Yeah, absolutely.
So I tend to use that as a first choice, and we can talk about the different types if you want to.
Well, I think people will have heard of different. So I generally will use Ostenal Plus, Durolane, Synovium. There's many more.
Yeah, there's many more.
So tell us a little bit about your preference and what the differences are.
Okay, I mean, so the hyaluronic acid can be modified, right? So it's not all the same molecular structure. So you can get higher molecular weight hyaluronic acid, or you can get lower molecular weight hyaluronic acid. You can get hyaluronic acid that's cross-linked and ones that are not cross-linked. So they're the two differences. Generally speaking, if you've got something that's high molecular weight, it's probably a little bit more potent. Probably lasts a bit longer. If you've got cross-linking, that probably will reduce the degrading of the hyaluronic acid, so it will last longer. So my preference generally is to use something that's high molecular weight and is cross-linked. However, Durolane would be something that I tend to use a lot of. Whereas, Ostenal Plus, not cross-linked, medium molecular weight, probably not as potent, or that's debatable. And, my second choice as an overall hyaluronic acid. Now, I think if you look at anecdotally at some of the evidence for side effects, I think it would be reasonable to say that some people think Durolane might be a bit more irritable for the joint
because of the high
molecular weight, and that some people get reactions to it, but that reaction can also occur with other hyaluronic acids. Yeah. But I think anecdotally we hear of potentially a little bit more of a reaction to something that's high molecular weight that's quite potent. And I think that's something that you need to educate the patient about. And that's how I say it. I say, look,
might get worse before it gets
your
better.
Choice. Sort of you can go for the higher, more potent hyaluronic acid that lasts longer, that probably will be more potent for you and might have a better effect, versus something that is a bit milder, but perhaps maybe a less chance of a reaction. Yeah. And again, if you're going skiing next week, maybe go with the Ostenal Plus or the medium. If you've got something really important in a couple of days' time, you might want to look at something that's a bit milder. If you're not fussed, if you do get a reaction, then it's your choice. But I tend to push them toward maybe a bit more high molecular weight, and then if they respond to that, then I'm pretty confident they'll respond to their second, third, fourth, fifth injections if they wish to continue with injections. There was a really good paper published by James Fitzpatrick, a sports physician in Australia a few years ago now, looking at a cohort of patients with hip and knee osteoarthritis. And she followed these patients over 6 years, and they had repeat injections. And she found that you had about a 65-70% chance of responding to the first injection. But if you respond to the first injection, then your rate of response to the second, third, fourth, fifth injections for up to 5 injections is about 80%. Oh, so I think it was a nice little study.
That was specific hyaluronic acid?
That was a Durolane injection. So I think it's a good little study to say to patients, I think if you respond to one, then I think you're more likely to respond to the second, which makes sense, right? You respond to one, more likely to respond to the second.
How many times, and we can both say that we've done it, how many times have you done, say, a Durolane and it hasn't worked, and you've tried another brand and
that's a good question.
And it has worked?
I mean, I think that does happen too.
Yeah, I've had a few cases.
I think that has. Saying you try Durolane, doesn't work. You then do Ostenal Plus, does work. Not sure why that is. No. Is it the drug itself? Don't know. Or vice versa. Tried Ostenal Plus, doesn't work. then use Durolane, it's worked.
But there's so many confounding variables there as well, because you don't know what they've done after the injection.
Exactly.
So it's difficult. Okay, so we've talked a bit about hyaluronic acid. We've talked a little bit about steroid. Let's go on to PRP, or platelet-rich plasma. Do you want to just give us a bit of a background as to what that is and how that fits into your current practice, if it does much at all?
So, in essence, PRP, platelet-rich plasma, is serum that has a high concentration of platelets. So what you're doing is you're taking blood, you're spinning the blood down, and you're super concentrating the platelets within the serum. So you centrifuge the blood, and that centrifuge then forces the heavier red cells and white cells into the lower part of the tube. And then the upper part of the tube, you've got serum, which contains then the lighter platelets, and you separate that plasma, and then that which contains the platelets, and then you inject that into whatever target you want to inject. So
generally joints, but also it is used, isn't it?
Generally
for
joints.
tendons?
It's also used for tendons. Now, if you look at the evidence, there's
talk to us about why are we after these platelets? What's that going to do inside the joint?
Okay,
or
that's a
the
good question. So platelets have lots and lots of growth factors. They also have lots of cytokines that are anti-inflammatory, and the theory is that you inject this serum which contains the platelets go into the joint or the tendon, joint, and they then release these growth factors. So they activate, and then they release these growth factors, and these growth factors then stabilize the joint. So if you've got osteoarthritis, you often have a high amount of inflammatory cells and low amount of anti-inflammatory cells, and you're just trying to equalize that. So the joint, and this is the way I explain to patients, is like having a joint that is sunny. It feels good for a while. You're not actually changing the pathology. So the pathology is still there. The articular cartilage pathology is still there, but you're actually making the joint feel better for longer. Similar to hyaluronic acid, because that's what hyaluronic acid does.
Yeah, sort of a homeostasis in the joint.
It just rebalances the inflammatory, anti-inflammatory markers, which are tilted one way in osteoarthritis, and then you're rebalancing it. So you're injecting these platelets in.
A lot of this is still theoretical, though, isn't it? As in, a lot of the evidence falls short in terms of we don't know exactly what happens inside that person's knee in terms of the processes. It's been proven, if you like, in vitro, hasn't it?
I think for me, it makes a bit of sense for osteoarthritis. Yeah. Because we know that there's this mismatch in osteoarthritis. The balance shifts towards inflammatory mediators. Right, so it makes sense you inject these anti-inflammatory mediators that come in and they stabilize it. Makes sense to me. Tendinopathy, tendinosis, it's a little bit more incredulous in the sense that tendinopathy is such a complex pathophysiological process, which we don't really understand that well. We have some sort of idea. We don't. I think it's a bit of a stretch to think that these platelets go in and then suddenly they change the structure of the tendon. But for osteoarthritis, I'm a little bit more comfortable accepting that PRP has a role, and a theoretical role as well, of rebalancing that anti-inflammatory, inflammatory.
Because I suppose the bit that, just put simply, is if you do have a inflammatory arthritic knee, we know that the evidence on tendons is all potentially an opposite process going on in terms of it being more not such an inflammatory problem, although there is controversy around that.
There's mixed degradation, inflammation in tendinopathy, and certainly there's increasing evidence recently of this role of inflammation and certainly chronic inflammation in driving tendinopathy. Yeah. So I think it's a little bit more precarious when we're trying to support the role with PRP and tendinopathy. I can see a role in osteoarthritis a little bit more clearly, and I'm a bit more comfortable actually injecting PRP for osteoarthritis than I am for a tendinopathy.
I'm going to make this personal, Lorenzo. I do know that you've had a PRP injection for your proximal hamstring.
Yeah, which looked awful, right? You've seen it.
Yeah, I've seen the scan, and it looked like a very old man's tendon.
Oh, thanks, Chris.
One that we see, sort of tendon we see every week. We see
middle-aged male,
middle-aged,
going crazy with their running.
So
has a slip.
You opted for a PRP injection.
Yeah.
Had you had a steroid?
No.
So you went straight for PRP because obviously steroid.
To be
fair, how's it going?
It's actually doing really well.
Is it going well?
I don't know if there's other factors involved, but I think.
But pain's getting better?
I'm back running, yeah, and I'm back running now. Was it the PRP or my strength training? It was probably majority of my strength training that I was doing.
Yeah.
Just chipping away, getting stronger.
Did the PRP motivate you to get strength training?
Look, I'd like to think that there was a role
Yeah.
for PRP in that, and I think it certainly. I'm not sure exactly what the factors were, but
who
I
cares?
noticed a couple of months later that I'm thinking this feels better.
So it did take
stronger.
a few months.
It took a few months, certainly to work. And generally PRP injections for tendons, they tend to get worse before they get better, and that's part of the education
find that?
process. It wasn't too bad. I mean, it was good to go through that experience as a patient.
Yeah, absolutely.
It was a great learning experience for me. And
Yeah.
I'm actually doing a study at the moment on hamstring tendinopathy.
Well, we might get into that one.
So it was all happening. Yeah. I was actually I should have been part of the study myself. But I think
biased,
I think slightly biased. But I think I think there is a role. I think there is a role. Certainly in the osteoarthritis, if you look at the evidence, there's certainly some good evidence. Now the problem with the evidence is, and this is the issue with PRP, is there's so many confounding variables, and that's not even looking at the patient itself. That's looking at the machines they use. So
let's explain that. So basically the way you prepare the PRP, all the studies are very heterogeneous. They're all doing it a different way.
They're all doing it with different systems. It's like saying you've got 100 different drugs, and we're doing it for the same. But all these drugs are similar, but they're slightly different. And we're treating the same condition, and then we're trying to compare one against the other, and it's really difficult to come to some sort of conclusion.
And so the variables are how much blood you take, therefore how many platelets you get,
how many
injections you do,
Yeah. Also the variables about the patient itself. How many platelets do you have? And not only platelet number, but how effective are they? There's so many variables in PRP that.
Is that why we get so many variable results, or do you think that's
I
just
think that's
the way
part
it
of
is?
it? And I think if you look at some of the studies on PRP, you see this huge variation in results.
Yeah.
So what we call the standard deviation or the variance of the results are huge. So cortisone and hyaluronic acid a bit tighter, so not everyone responds, but you don't get this huge variation.
So
where you
slightly more predictable response with the other
predictable
two.
response. The PRP has a slightly better response than cortisone PRP, but the variabilities, the standard deviation of the scores are really high. So you've got some people that do fantastically, and then some people that do less than placebo.
But that's what you've got to inform your patient.
Yeah. So this is the thing: is that with PRP, it's quite promising, but. And we see these positive effects in the studies, but the studies are what I call very dirty in the sense that there is so much heterogeneity in the studies that it's really difficult to know. It's difficult to know what we should be using,
and on what condition, because a tendon might be different to a joint.
Absolutely. And I think there's a lot more work to be done on PRP. The issues with the studies, I think we need to compare the different types of PRP. So you've got higher platelet dose, you've got lower platelet dose, you've got whether something is spun once versus something that's spun double spin,
leukocyte-rich, leukocyte-poor.
So all these variables, and I think we need to make comparisons between the two before deciding on what one is most optimal. Nevertheless, I think the trend is definitely towards higher dose of platelets. But what that dose is exactly, we don't really know.
No.
We don't really know. Now, it seems like we need, on average, maybe about 5 to 7 billion platelets. And that might be, depending on standard PRP, that might be 2 or 3 injections. And now we've got, we've certainly got a new PRP system now where we do one-shot PRP. Where you could get that 8 billion or 7 billion in one shot. And certainly that's the trend that I'm working towards with my osteoarthritis and certainly osteoarthritis and tendinopathy is rather than doing 3 shots, you just do one.
Which is what you had done, wasn't it?
Which I had one done, which is the Arthrex ACP Max, where you would take 60 mils of blood, so take a lot of blood, spin it down twice, and then inject a super concentrated platelets, and then you're done. That's a lot more preferable than having to come back 3 times to have the injections. So things are moving towards a sort of a higher dose.
And I think and we talk about this in clinic, but I think the bit I struggle with injection therapy is And where it gets bad press is you just don't know if you know that steroid's going to work for a short period of time most of the time. But if we look at hyaluronic acid, if we look at PRP, there's other things we can talk about. We talk about, in fact, you can put stem cell into it or stem cell therapy, which we'll talk on in a minute. But you literally have to look the patient in the eye and say, this is appropriate because we know there's studies that say it can help, but I've got no idea if you're the person it's going to help. Or, dare I say it, at the other end of the standard deviation, the person that might get a bit worse.
Exactly. And that happens.
That does happen.
It happens. I mean, I think...
Is that where we are with it?
I'm just upfront with patients.
Yeah,
I say, look, you've got this condition, you've got osteoarthritis, you've got this. This is the drug I think you should use. But there is this other option if you want it, probably more expensive. Will it be better? I'm not sure. But I think we should start here and probably start with the slightly cheaper option. That might not mean cortisone. It might mean... hyaluronic acid or, PRP that's slightly cheaper. Yeah. But I think I'm upfront with patients, whereas people assume that if it's more expensive, it's better. And that's not necessarily the case at all.
I mean, steroid costs about £3 to buy, doesn't it?
The more expensive injections are not necessarily better. And we're seeing this in stem cells.
Yeah.
If you look at the studies on stem cells,
let's talk about stem cells. Just introduce that, because the ones that people might come across that I get asked about is BMAC.
Yes.
So this is the bone marrow where you get the stem cells from there. And then the other thing that people talk about is lipogems, which is where you get the stem cells from the fat. Do you want to just talk us through what we mean by that?
In essence, what you're doing, they're not true stem cells.
No.
In essence, what we're doing is trying to harvest these cells called mesenchymal stem cells. And these cells can proliferate into different cells, but we get these MSC cells, and we try and increase the concentration of them and inject them into joints and tendons. Now, the thinking is that they're somehow better than injecting hyaluronic acid or injecting platelets, but we don't know. And certainly the studies that have compared, say, stem cells to PRP have found that actually there's no difference between the two. There's actually a recent study looking at stem cells versus cortisone and finding actually that, in fact, there was no difference between groups. So I'm not entirely convinced that stem cells, given the cost, and given the potential morbidity associated with it, you have to take BMAC, you have to take from bone marrow, harvest your fat, which may be great cosmetically, but it may not turn out so well. So I think given the cost, I think I'm not completely supportive of people necessarily going to that. No. Having said that, I say to people, if you want to go ahead with stem cells, I think you should do it.
So it sounds like we've got quite a long way to go to find out and make that very individual care decision where you've got that patient in front of you and we know that X, Y or X is best for you. So we've been through most of the different types of injectables. Do you want to just sum up what we've said so far and where you think we are overall?
So I think injections, so first principle is always should be an adjunct to other therapy, preferably exercise therapy, supervised by a physiotherapist. So it shouldn't be a sole treatment. Secondly, you just need to be aware that there are pros and cons of each injection. So, certainly pros and cons of cortisone we've gone through. Just need to be careful about potential harm, but also look at the positives and negatives of hyaluronic acid and PRP. So I think it's a case by case decision about where we go to with injections. And the other thing is, I think it shouldn't be the sole treatment, as I mentioned, but also it shouldn't even be the second treatment. It should be really third and fourth treatments with other treatments that include education and rehab and activity modification and so forth. Yeah,
absolutely. And I suppose, and the overriding message, I suppose, for people that are considering injection therapy is find out a lot of information. Be cautious where you get your information from, because there's lots of clinics and websites that will sell these things quite well. But at the end of the day, we still don't know if you're that person that it's going to help. So that was really interesting, Lorenzo. Thanks very much for your time.
Thanks for joining us. I want to come back.
You can come back.